So many people are confused about not just psychiatry and psychology, because psychiatry and psychology sound really close, right? So people confuse them all the time.
Difference here between a psychiatrist and a psychologist.
Psychiatrist, focusing primarily on diagnosing and treating through medication.
Psychologist refers us particularly if someone has gotten a doctoral degree in psychotherapy.
It's like a puzzle where each piece holds its own uniqueness, yet together they form a breathtaking picture. You see, the art of thinking is where the real magic happens. It's the hearts of both psychiatry and psychology. It's about knowing when to act and when not to, recognizing patterns, and yes, embracing uncertainty. We're about to bridge the gap, weave connections, and shatter misconceptions, all with the aim of understanding the mental health landscape.
Hi everyone, welcome to Psychiatry Simplified, the world's leading psychiatry channel for all things psychiatry and neuroscience related. We combine years of clinical experience with academic knowledge with the aim of helping you understand the brain and the mind-body connection better. I'm Sunil Rigge, consultant psychiatrist, founder of PsychScene and Vita Healthcare. If you're new to this channel, be sure to like, subscribe, and turn on that notification bell. So let's get started.
If one Googles this particular question, often the answer is so simplified that it actually leads to a misunderstanding of what a psychiatrist or a psychologist does. The most common answer found, or answers, is that a psychologist does not prescribe medication, whilst the psychiatrist does. The psychiatrist has gone through medical school, while a psychologist hasn't. There is more to this than just looking at qualifications, whether they've gone to medical school, or medication. I'm going to take a completely different approach in answering this question because I'm not necessarily going to focus on the differences based on qualifications or titles or vocational labels. But the gist of the answer really comes down to the differences in the problem-solving approaches that both use. Why is the approach to problem-solving so important, not only in psychiatry, but in any problem that we're solving? For the purpose of this video, of course, I'm going to focus on how a psychiatrist thinks. And hopefully that will give you an understanding of the differences between a psychologist and a psychiatrist, but at the same time give you an understanding of how a psychiatric issues is approached broadly. Now, psychiatrists and psychologists work together very closely in order to address an issue, whilst at the same time, they work together to implement a plan together. This is done through the development of a strategy because there are certain phases at which a psychological treatment is more likely to be beneficial than if it's introduced at an incorrect phase. For example, in trauma-related disorders. We know that in some trauma-related disorders, one has to take a phase-oriented approach. If one simply looks at trauma and considers psychological treatment right at the start, this can lead to a worsening of the condition. The main difference between a psychiatrist and a psychologist is how problems are approached. That is, an understanding of the problem and the subsequent implementation of a strategy. A psychiatrist, as a result of their medical training, is able to, or more likely to, incorporate the biological factors and their relationship to psychological, sociocultural, diet, and lifestyle domains. These factors may be predisposing, perpetuating, causal, contributory, or maybe an effect, but by using multiple frames of thinking beyond the psychological framework with an understanding of the interaction of the biological aspects in a multi-directional manner, problem solving now has an extra layer, which becomes handy in influencing the final outcome. For example, in depression, the psychiatrist may be able to identify a melancholic depression with vascular factors, where cognition and activity is so significantly affected that psychological therapy may not help at that stage. The psychiatrist may also recognize that melancholic depression has a greater biological weighting, is more likely to be associated with vascular factors known as a subcortical depression. They may recognize that dopaminergic and noradrenergic potentiation is necessary or crucial in improving this cognitive and activity domain. Once this depression is treated, the patient is more likely to have a better outcome with psychological input. An important part of being a skilled clinician, whether a psychiatrist or a psychologist or other fields, is knowing not only when to do something or what's the right choice, but also knowing when not to do something. For example, I work with excellent psychologists that will come and have a discussion and say, I think CBT at this stage is unlikely to work, or trauma therapy is unsuitable at this stage. Do you think you can consider biological interventions to reduce hyperarousal or to improve cognitive function so they can engage better in psychology? Even though they haven't gone through medical training, there is the knowledge sharing between psychiatrists and psychologists that makes this discussion possible. Similarly, I would have a discussion with my psychologist colleague to see if they can work on a specific set of psychological elements, such as enhancing distress tolerance or enhancing emotional regulation, as the formulation of the patient revealed that emotional dysregulation is less likely to respond to medication treatment. Effective implementation of a strategic management plan requires a very good understanding of the problem first. As Einstein said, in solving a problem, spend 95% of the time understanding it first and then 5% implementing that plan. In understanding a problem or an issue, in this case a mental health condition, all of us have a frame or a framework that attributes meaning to the issue or issues. And based on this frame, one would seek the respective solutions. For example, if our frame is that diet is core to mental health issues, then we seek out dietary interventions only. Similarly, for some, meditation or mindfulness may be considered beneficial, but if that's the only framework they consider mental health issues within, then they're more likely to only consider meditation to treat mental health issues. Now, each of these aspects may help a group of individuals, but not help others, or in some cases, may worsen things because it depends on a multitude of factors. And this is when we've got to understand, am I thinking about things within a narrow framework, and do I need to expand my framework? Now, there are hundreds of different therapies one will come across outside the evidence-based therapies that propose to solve mental health issues. Will they solve them in some individuals? Absolutely. But why don't others respond? This is where the frame matters, because solving a problem isn't just about one, knowing what to do, but also knowing what not to do, and when to do something and when not to do something. And for this, we need to know the whys, the Socratic questioning in a way. If an individual thinks of the why within one frame, they succumb to anchoring bias and confirmation bias. As Mark Twain said, it ain't what you don't know that gets you into trouble, it's what you know for sure that just ain't so. And this applies for psychiatrists as well. We've always got to recognize that the patient, the brain, is extremely complex. And in the initial stages, one may succumb to confirmatory bias. True problem solving utilizes two key modes of thinking and an understanding of causality. This was well described in Kahneman's book, Thinking Fast and Slow. There is the system one, which is the fast thinking, and this is related to heuristics. Heuristics are important because it helps problem solving. It helps us problem solve quicker. There is the system two thinking, which is linked to falsification of hypotheses. Now, how do we falsify hypotheses? We falsify them by expanding the range of hypotheses for a given problem. So in psychiatric problem solving, we consider a diagnostic hierarchy. We think about, is this organic factors? So we try to rule them out. We look at substance use. We look at what medications have been prescribed. Could the medications be causing or contributing to the symptoms of patients presenting with? Next, we look at the mesolimbic system or the activation areas. Then we think about the nature of depression. Then we think about anxiety, trauma, past and current stresses, OCD, eating disorders, and finally, personality structure. We think about neurodevelopmental aspects. We look at sleep disorders. We will then go through a falsification process, gradually ruling things out so that what remains must be the most likely hypothesis that we can now start working with and implementing a plan. I've covered this in another video on the channel, really looking at how psychiatrists think. Besides these two modes of thinking, we also have to combine clinical experience, because this is where powerful problem-solving learning comes in, pattern recognition. And this requires experience as it gets better with time. It's like chess. We know that experienced chess players see the board differently over time. A study done looking at visual patterns of chess players showed that chess experts can rapidly differentiate complex chess-related visual patterns. The study looked at experts versus novices, and here chess players viewed an array of 4 minimized chessboards and rapidly searched for the target board that allowed a knight piece to reach a target square in 3 moves. What they found is that the experts showed longer first fixation durations on the yes board that allowed that knight piece to reach a target square in 3 moves. So they've had longer first fixation on that yes board relative to the difficult no board. This task actually strongly differentiated chess skill. Reaction times were more than 4 times faster for the experts relative to novices, which shows that they were able to recognize patterns. This is also linked to the experts' tacit or implicit domain-related knowledge in medicine, which really comes with experience. It's what we also call intuition or gut instinct. Kurzweil said, "Human beings have only a weak ability to process logic, but a very deep core capability of recognizing patterns. Humans have a capacity store of 300 million pattern processors, each composed of 3 parts: input, pattern recognition, and output." How is it relevant for clinical reasoning? Clinical reasoning consists of iteration between discipline-based information, which is the evidence, plus observational analysis. Pattern analysis is advanced and constantly recalibrated by progressive clinical encounters and less by evidence, because evidence usually gives us a certain subset of individuals. We know that evidence-based guidelines often include patients that may be less unwell, may not have comorbidities, whilst real world is very, very different. And therefore, our pattern analysis, pattern recognition is improved more by progressive clinical encounters with observation and less by evidence. And therefore, in clinical practice, it becomes crucial to observe closely, but at the same time with our observation, constantly ask questions and falsify our hypothesis at each step. So coming back to the question, what is the difference between a psychiatrist and a psychologist? 1, it's utilizing both systems of thinking, system 1 and system 2, to falsify hypothesis. Now, both psychiatrists and psychologists may do it, but the psychiatrist is more likely to take on the pattern recognition aspects utilizing multiple frames beyond just psychiatry medical training. They would look at psychological, psychosocial, diet, lifestyle aspects, but more importantly, the link between biology and these other domains. In psychiatry, as clinical practice proceeds, which is where the expertise comes in, the application to clinical experience that every individual is different and individualized formulation becomes important. This links to the Dunning-Kruger effect. Usually confident statements or overconfident statements highlighting one aspect as a solution usually highlights this Dunning-Kruger effect. Because what I find in clinical practice is the more I learn and observe, I realize the less I know at the start. My hypotheses are constantly changed or falsified, and then I've got to move beyond that framework to then learn more. So therefore, in psychiatry, I'm more likely to take on a probabilistic approach or probabilistic thinking approach to solve the problem. Because right at the start, I possibly have 3 or 4 hypotheses. I then have to think about the most likely one, falsify it, and then move to the next one. Now, of course, in the process of falsifying, I might find that that is the most likely hypothesis because the patient gets better, for example. These hypotheses incorporate the biopsychosocial cultural diet lifestyle approach. For each aspect, recognizing the impact of each domain in different directions, multi-directions. For example, biology is linked to diet, so diet may worsen biology, but psychosocial aspects may have led to individuals not being able to, say, for example, eat the right food because of financial difficulties, which indirectly then affect biology. On the other hand, individuals may have cognitive impairment, which makes it very difficult for them to, for example, independently go shopping for the right dietary intervention. So this is where we'll look at causality in a bit more detail. It's common to hear statements such as this medication causes this particular side effect. Or in psychiatry, it's so common to hear about this is the root cause. In psychiatry, we must go to the root cause of finding the problem. Or for example, because trauma is the root cause, trauma needs to be addressed. But this actually highlights a misunderstanding of causality and the complexity of the interactions between a biopsychosocial cultural diet lifestyle formulation. Why is this so? Let's take an example of an individual who's now an adult with depression or, say, psychotic illness. So let's think about that, either depression or psychotic illness. Now, if we backtrack to their life, let's say they've experienced trauma in childhood, which led to sleep disturbance in adolescent years. This sleep disturbance led to daytime fatigue. As they move forward through life, it started affecting their work so that it led to work underperformance. The work underperformance led to low self-esteem. This low self-esteem initially affected their confidence, and individuals started developing feelings of low self-esteem, low self-worth, etc. Now, at this stage, they did not develop the more severe forms of depression, but at this stage, they started coping with substances, for example, alcohol and cannabis. Now, cannabis led to the involvement of subcortical circuits, the basal ganglia. Now, we know cannabis leads to an amotivational syndrome. So this cannabis led to amotivation, which further affected both their cognition, but also affected their motivation, which further affected their self-esteem and further led to work underperformance. On the other hand, there might be another individual that used cannabis, but because they had a vulnerability, they developed psychosis. So let me stop here and ask, based on this particular story that I just described, what is the root cause? Was it the trauma in childhood? Was it the cannabis? Was it the daytime fatigue? Was it the sleep disturbance? I guess what I'm trying to highlight is that there isn't a root cause. Searching for one root cause often leads us to miss all these other factors that are playing a part. If one thinks of trauma as an underlying cause and refers this patient to trauma therapy, the likelihood, and note I say the likelihood of worsening, because there is a possibility that some individuals improve because they've gone through trauma therapy, but the likelihood or the probability in these situations is lower. So the likelihood in the context of trauma of worsening is high, as if the individual has hyperarousal symptoms because of poor sleep, which is what we call the emotional undermodulation phenotype in PTSD, then they're more likely to worsen with trauma therapy, as the prefrontal cortex is not able to control all those primitive memories, traumatic memories that they've now got to process. The amygdala will start firing, and that's when the cascade towards worsening of trauma-related aspects happens. It's common in clinical practice to see patients who've tried everything: diet, exercise, meditation, mindfulness, natural supplements, and then seen a psychologist, and then finally come and see a psychiatrist. Many are very, very hesitant to see a psychiatrist. There is, without a doubt, a huge stigma against psychiatry and psychiatric medication. But when one actually thinks about the fact that brain's an organ and controls and really a lot of the top-down processes that makes us a human, one's got to recognize that psychiatry plays an important role. Now, in these situations, when the individual's gone through diet, exercise, meditation, mindfulness, etc., they've gone through their frames of causality. They've thought of diet, they've then thought about calming their mind down, they've thought about exercise, so they've covered their frames. They've gone through the falsification of hypothesis. But if things haven't improved, because for others, they've tried this and things have improved, I'm very unlikely to ever see them. But for many, when things don't improve, now they come and see a psychiatrist, because knowingly or unknowingly, they're looking to expand their frames of thinking or problem solving to solve their issue. What they're trying to do is to derive insights for themselves with regards to their problems or issues. But there are individuals who may be very fixed in their frames of thinking, either as a consequence of illness or other cognitive reasons, such as trust, such as very fixed beliefs about what illness constitutes, whereby not attempting to expand their frames can lead to detrimental outcomes to themselves or their families at times. Causality is multidirectional. So in this patient that I talked about earlier with psychosis or depression, if one says the root cause is trauma and seeks only trauma treatment, then they've missed out all these other factors. The initial framework is recognizing the various elements of causality. And what are they? We have true causality, reverse causality, other confounders, biases, and then a chance association. So there are 5 different relationships when we think about causality. Similarly, from causal factors, there may be factors that might be a component cause, a necessary cause, or a sufficient cause. And in some cases, factors may be all 3 or just one. So in the previous example, cannabis may be a component cause. One might say that cannabis in some individuals may be a component and a necessary cause. In the same individual, trauma is a vulnerability factor, and trauma may have created a neurodevelopmental vulnerability. This is likely impacted on arousal system, emotional regulatory systems, leading to sleep deprivation. Early on at this stage, psychological treatment may assist the individual to interrupt or prevent further worsening. Mindfulness and sleep interventions at that stage is likely to have worked in some individuals, but sleep deprivation moving forward affects prefrontal cortex function and further increases hyperarousal. So now we've got a cascade. This prefrontal cortex Involvement is presenting as fatigue affecting cognition, activity, reward experiences, and acts as a vulnerability for depression. Then further factors, work issues, low self-esteem, coping strategies include alcohol and cannabis, which may have turned on the switch in individuals with a genetic vulnerability. So therefore, in solving this issue, the recognition that psychotic symptoms require a biological input initially becomes important. The major issue, and I see this a lot, in the patient that we saw above, along their journey, they may come across other friends or family or professionals with fixed frames who may suggest try meditation, or you must go through EMDR for trauma, or try cannabis oil, or you are using the wrong type of cannabis, try psychedelic therapy, etc., etc. And I wish it was so easy. I wish there was a single thing that would treat individuals and address all their issues, treat their perception and activity and cognition and sleep and emotion. As Gawande says, we always hope for the easy fix, the one simple change that will erase a problem in a stroke. But few things in life work this way. Instead, success requires making 100 small steps go right, one after the other, no slip-ups, no goofs, everyone pitching in. And this everyone is where, as a psychiatrist, I work with psychologists, physiotherapists, mental health nurses, occupational therapists, dietitians, to come together with the varied frames to problem solve. If someone asks me whether psychedelics work or trauma therapy work or X or Y treatment works, and often many of these questions come about in clinical practice and of course on these video comments as well, which are helpful for me to know how individuals think, and I try to answer them in the best possible way. But if someone asks me this, one thing or the other works or not, my answer would be I don't know, because in order to say yes or no, I need to understand the individual's symptoms, their history, their past experiences, their medical history, and then develop a formulation incorporating all of these and then implement a plan, because that would be the appropriate and fair thing to do. It's easier for me to say yes or no, but it's actually could be even harmful for certain individuals without understanding their makeup. Medicine is complex and psychiatry even more. Again, as Gawande says, expertise is the mantra of modern medicine. In the early 20th century, you needed only a high school diploma and a one-year medical degree to practice medicine. By the century's end, all doctors had to have a college degree, a 4-year medical degree, and an additional 3 to 7 years of residency training in an individual field of practice, pediatrics, surgery, neurology, or the like. In my case, I entered medical school in 1997 and I finished and I got my psychiatry qualification in 2007. Subsequent to that, got the second psychiatry qualification, again around 2009 is when I became a consultant. So you can see it takes about 12 years from entry to medical school in order to specialize. In recent years though, and I agree with this, even this level of preparation has not been enough for the new complexity of medicine. And what we realize is much of what's given in textbooks doesn't apply in the real world. So that's when the whole process of falsification of hypothesis starts and a new era of learning begins for me. So let's come back to the original question. What's the difference between a psychologist and a psychiatrist? I really don't know what the best answer is. What I do know is that problem solving in mental health issues requires an expansion of frames. Psychiatrists differ in their approach because they're incorporating some additional layers, additional frames, particularly the biological frame and the interaction of these biological frames with other psychosocial, diet, lifestyle frames. So it's almost like, as they say in the tortilla ad,
¿Por qué no los dos?
Which basically means I would work with a psychologist as a psychiatrist together and possibly with other specialists as well. So, ¿por qué no los tres o cuatro? You may be already working with a naturopath, dietitian, meditation guru, etc. But why not learn through a discussion with other specialties? It may include a psychiatrist as well, because the consequence of missing a frame in some cases means that the individual misses an opportunity for intervention. So I hope that this video has helped you journey beyond the familiar, beyond the mundane, beyond the simplified explanations, and explore the unity within diversity. It's time that we unlocked a deeper understanding of how both psychiatrists and psychologists come together to create a healthier world of mental well-being. It's important that we think outside the box, think beyond the frames. Until then, keep exploring, keep learning, and most importantly, keep questioning. Bye for now.